First talk is by Dr. Leema on HYPHEMA Demystified from Impact to Intervention. Leema did MBBS and PG from Government Medical College, Trivandrum. She is currently working as Associate Professor at Government Medical College, Kottayam. Over to you, Leema.
Thank you. And the topic is HYPHEMA Demystified from Impact to Intervention. Now, HYPHEMA, as you know, is blood in the anterior chamber. It's important that you treat it properly because it can cause permanent vision impairment. Now, the causes of HYPHEMA are traumatic causes, and also there are non-traumatic causes. Here, the focus of the talk will be on the traumatic causes, especially in blunt trauma, which is around 70% of the HYPHEMA is associated with blunt trauma. It's very common in sports injuries, accidents, and assaults, workplace accidents. So therefore, it has got high medico-legal importance. Higher prevalence in adolescents and young adults, and males are affected more than females. Basically, the mechanism is rapid anteroposterior compression of the eye with equatorial expansion and increased IOP, which leads to shearing forces that tear the vessels of the iris and ciliary body and fill the anterior chamber with blood. Now, clinical presentation. So usually patient presents with a history of trauma with a sudden decreased vision. There will be pain and photophobia, and there will be visible layered blood, which should be graded according to the American Academy of Ophthalmology from a microhyphema, which is grade 0, to a grade 4, that is the 8-ball hyphema. 8-ball hyphema occurs because the anterior chamber is filled with blood, and because of that, there is the aqueous circulation is impaired, and this leads to oxidation of the blood, and it attains that black color which we associate with the 8-ball in a billiard. Now, it also will have an elevated IOP or even a hypotony depending on what happens. So associated injuries are quite common, and globe rupture being one of the most important thing, and you should rule out that. Angle recession, traumatic iritis, Vosch's ring, traumatic mydriasis, iridodialysis, cyclodialysis, where you will get a decreased IOP, and corneal changes will also be there. And also there will be cataract, vitreous hemorrhage, and all the posterior segment findings associated with trauma. Now, complications would be, the first one obviously is the obstruction of trabecular meshwork with associated increased intraocular pressure, which is seen in around 30% of patients, and formation of the peripheral anterior synechiae and posterior synechiae if the blood remains in the anterior chamber for a long time. Corneal blood staining is seen in 2 to 11% of patients, and the first sign is the presence of a fine, deep yellow line in the stroma, especially central, and followed by extension in 24 to 36 hours. And this also clears in months and years from the periphery towards the center. There might be pupillary block because of the blood, and amblyopia is a concern in the pediatric age group, and rebleeding can occur. Rebleeding typically occurs in the first 3 to 5 days, and it occurs when the initial clot lysis in the fragile damaged vessel wall breaks down, and typically more significant than the initial bleed and carries higher risk of complications. So these are there are some risk factors associated with that. You identify it by you can see the layered blood. You see a little oxidized blood in the bottom of it, and then you have a fresh blood more on top of it. So initial evaluation, you should ask for the trauma type, because we would need to know whether there is a possibility of intraocular foreign body or a globe rupture. And examination includes visual acuity, slit lamp evaluation, IOP measurement, and if there is a suspicion of open globie, no tonometry should be done. Fundus evaluation, if you can't see it, use a B scan or a CT scan depending on what the suspicion is. Management, in the short term, you manage with rest. Head-end elevation is important because it clears the visual axis as well as reduces the amount of cornea and angle which is in touch with the blood, so that the changes won't happen. Then topical use cycloplegic, topical corticosteroids, beta, and better to use aqueous suppressants rather than will be a better choice for anti-glaucoma. And we say that there is the risk of changes in the angle and all is high for a patient with sickle cell anemia. So therefore, a smaller grade of HYPHEMA itself should be taken as serious in that. And carbonic anhydrase inhibitors should not be given because it will increase the sickling. IV mannitol and antifibrinolytics may also be tried. Indications for surgical intervention may be required in 5% of cases. indication is more than 50 millimeter for 5 days and more than 35 for 7 days. But in case of total HYPHEMA, the threshold is lowered. And in sickle cell anemia also the threshold for surgical intervention is lowered. Corneal blood staining is another indication. Large stagnant clothes persisting for more than 10 days. And in pediatric cases, in case you're concerned about amblyopia also, you can intervene. Surgical interventions would be paracentesis, bimanual cutting and aspiration for clotted HYPHEMA, and other surgical interventions include peripheral iridectomy if you're suspecting a pupillary block, and trabeculectomy may have to be done in recalcitrant glaucomas. In long-term management, you should look for complications such as traumatic cataract, traumatic mydriasis, angle recession, and regular long-term visits might be instituted. Outcomes and prognosis. In more than positive outcomes with early intervention, more than 74% of patients have a good prognosis, and prognosis is worsened by rebleeding, high-grade HYPHEMA, blood dyscrasias, angle recession, and poor visual outcome only because of HYPHEMA is seen in 11% of cases. And take-home message, it's a time-sensitive thing, and you should know when to manage conservatively and in surgically, and you should follow up these patients. Thank you so much for your